Okay. So good afternoon. I decided for Grand Rounds today to talk about primary hyperparathyroidism for a couple of reasons. It's not an uncommon disorder. It's frequently seen in primary care internal medicine as well as a variety of medicine subspecialties. And sometimes the treatment decisions are a bit difficult because we're usually trying to balance a recommendation for surgery versus observation. And so over the years, groups of experts have gotten together and developed consensus statements regarding hyperparathyroidism. The first consensus conference was in 1991. There have been about 4 since that time. And the last conference and guidelines that were published were in 2014, 6 years after the previous guidelines were released in 2008. So I thought this would be a reasonably ripe topic to discuss at Grand Rounds. I have no conflicts of interest with the information in the talk. And we're not moving ahead here. Okay. And so the learning objectives are to be able to take a patient with hypercalcemia and arrive at the proper diagnosis, recognize the complications of primary hyperparathyroidism and how they guide us as clinicians to recommend treatment for our patients, and to describe those tests and possible treatments that we might use in patients who do have the disease that are not considered surgical candidates. So here's data from Kaiser Permanente, a very large population of patients followed in Southern California over a 15-year period of time, noting the incidence and also a tripling of the prevalence from 1995 to 2010, up to 233 per 100,000 women and 85 per 100,000 men. So let's begin with a case. A 62-year-old man for 6 years is having recurrent kidney stones. He's had a fragility fracture of a vertebral body, significant hypercalcemia, 12.1, even higher corrected, with a high PTH, and a urine calcium that's consistent with primary hyperparathyroidism. So appropriately, you order a parathyroid scan, and on the early image, at 10 minutes, you see it in the salivary glands, the thyroid, the heart. You, in reality, can make out that he likely has a left lower parathyroid adenoma. But at the 2-hour time interval, the isotope has largely cleared from the thyroid and now shows a nice, distinct left lower parathyroid adenoma. So what do you recommend for this patient with stones, fractures, and calciums of 12? I would expect all of you would call a surgeon, and this patient needs surgical management and cure of his disease. Now, this is the same patient with the same complications and the same level of calcium, but in this case, his parathyroid scan is negative. What are you going to recommend for this patient? And I'll give you some choices. I'm not going to ask people to raise their hands because I know what happens. 3 or 4 people will respond, and I'll just be looking out at the audience. But pick your answer and see if it matches up what you might do at the end of the hour. Should you identify an experienced parathyroid surgeon and get him to the operating room? Just wait and repeat the calcium in 6 months? Start some cross-sectional imaging looking for a cancer-causing hypercalcemia? Advise the patient, well, you do have hyperparathyroidism, but since the scan is negative, you can't have surgery. We're not sure what to do. Or begin treatment with alendronate since he has a fragility fracture. So a little physiology. Calcium is in several compartments in the blood, highly protein bound, about 40%, mostly to albumin. About half is ionized, free, and a small percent is complex to anions like citrate and phosphate. Remembering that changes in albumin concentration can affect the total but not necessarily the ionized calcium. And protein binding is affected by acid-base states, decreased binding and increased ionized calcium in states of acidosis, increased protein binding and lower ionized calcium with alkalosis. So most people, I expect everybody is familiar with the corrected calcium formula. You take the patient's measured albumin, subtract it from 4, multiply that by 0.8 and add it to the measured calcium to get the corrected calcium. So here's a patient with a seemingly normal total calcium of 9.6 but an albumin of 2. This patient is in fact hypercalcemic. Or we might have a patient with a low total calcium of 7.4 and that same low albumin of 2, and this patient is corrected calcium is normal. And when in doubt, we usually don't need to do this frequently, but when in doubt, you can measure an ionized calcium. We're ingesting calcium in our diet, about 1 gram a day. The intestinal absorption of calcium and phosphorus increased by 1,25-dihydroxyvitamin D. Bone is metabolically active on a daily basis. About 500 milligrams of calcium is resorbed from bone, 500 milligrams deposited. Resorption increased by PTH and 1,25-dihydroxyvitamin D. The ionized calcium is freely filterable by the glomeruli. So if you have normal renal function, you filter about 10 grams of calcium a day, a huge amount, but net urine calcium excretion is typically less than 200 milligrams a day. 98-99% of the filtered calcium is resorbed. Several mechanisms, one of which involves the distal tubular resorption increased by PTH. You can't talk about PTH without thinking about vitamin D, an inactive prohormone produced in the skin under ultraviolet light or ingested in the diet, hydroxylated at the 25 position in the liver, and the main organ regulating vitamin D metabolism, the kidney, where the 1-alpha hydroxylase converts 25-hydroxy-D to 1,25-dihydroxyvitamin D. And important to remember, PTH increases the 1-alpha hydroxylase, as do states of low phosphorus. Okay. When we assess somebody for vitamin D deficiency, while we recognize 1,25-dihydroxy-D is the active hormone, vitamin D, 25D, is stored in adipose tissue. We use 25-hydroxy-D levels to define if someone has vitamin D deficiency. And in primary hyperparathyroidism, 25-hydroxy-D levels are typically low, whereas 1,25-dihydroxy-D levels are usually high normal or slightly high due to the effects of PTH and low phosphorus activating the 1-alpha hydroxylase. Now, I'll address this issue here. What defines a low vitamin D? You've probably seen a number of reference ranges in recent years. Some saying vitamin D deficiency is a 25-hydroxy-D less than 20, others less than 30. So why the controversy? The Institute of Medicine, looking at evidence-based data and saying what is a level of vitamin D that is healthy for bone metabolism, has arrived at the conclusion that a level above 20 nanogram per ml would be vitamin D sufficient, less would be deficient. Other organizations like the Endocrine Society feel a low vitamin D is less than 30. And here's some data supporting that value of wanting that 25D greater than 30. These are a group of postmenopausal women looking at 25-hydroxyvitamin D levels versus PTH levels. And what you see is as vitamin D levels decline right at about 30 nanogram per ml, there's an inflection point in this curve where PTH levels start to rise. And the conclusion of data from like this is that the earliest biochemical manifestation of vitamin D deficiency is an increase in PTH that occurs before you see a drop in calcium or a drop in phosphorus. You start to see secondary hyperparathyroidism. So the causes of hypercalcemia, whenever you're faced with a patient, hypercalcemia is not a disease. You've got to find the cause and divide them into PTH dependent and PTH independent. Most often, primary hyperparathyroidism, 80-85% is single adenoma, a smaller percent multi-gland disease, and rarely parathyroid carcinoma. Lithium, a drug that alters the set point at which calcium inhibits PTH production, resulting in more generous PTH levels. About 5% of patients on chronic lithium may get hypercalcemic. And lastly, familial hypocalciuric hypercalcemia, an autosomal dominant disease. Here we have a classic curve looking at the relationship between changes in calcium level and PTH production. High levels of calcium will suppress PTH. As patients become hypocalcemic, PTH production is increased, which should in turn start to raise the calcium. We've known this relationship for many, many years, but it was probably about 20 years ago when the mechanism by which parathyroid cells can sense a change in extracellular calcium concentration was identified with cloning of the calcium sensing receptor, which is a G protein coupled receptor. Calcium is the agonist in the extracellular portion of the molecule, and when activated, this receptor will decrease PTH production from parathyroid cells. The same receptor is on the C cells of the thyroid, where it increases calcitonin secretion. It's present in the renal tubule, where it decreases resorption of calcium and magnesium, in essence, increasing urine calcium excretion. So if you have an inactivating mutation of this receptor, you get increased levels of PTH, which leads to hypercalcemia. But because of the effect of this receptor in the kidney, you wind up with low urine calcium, hypocalciuria. So familial hypocalciuric hypercalcemia, it's autosomal dominant. We differentiate it from primary hyperparathyroidism by quantifying the calcium in the urine. And if you think it's primary hyperparathyroidism, you miss the diagnosis and send the patient for surgery, almost always the patient's going to wind up with failed surgery or recurrent hypercalcemia. And these patients typically have mild hypercalcemia, no bone disease, no renal disease. They're asymptomatic. You diagnose them, but you don't need to treat them. There are a number of PTH-independent causes of hypercalcemia, from cancer to vitamin D intoxication, granulomatous diseases. You can read down the list. I'm not going to go through them in detail. So when you're faced with a patient with hypercalcemia, the first thing you should do is get a simultaneous measurement of calcium and PTH. And if it's PTH independent, the PTH levels ought to be suppressed, whether it's cancer, whether it's thyrotoxicosis, whether it's sarcoidosis. And if the PTH is not suppressed, certainly if it's elevated or even if it's in the high normal range, this is consistent with primary hyperparathyroidism. Now I've drawn in this little box here in someone with a calcium of 11 and a PTH that's high normal. What does the patient have? Well, you have to look at this and say, this PTH is inappropriately normal. If the calcium is 11, the PTH ought to be low. And if it's not low, particularly if it's in the upper range of normal, this is certainly consistent with primary hyperparathyroidism or FHH or lithium. So how often do we see normal PTH levels in primary hyperparathyroidism? This is a huge parathyroid surgical practice in Tampa. They do thousands of cases a year, and this is a nomogram looking at the PTH levels in these patients with surgically confirmed primary hyperparathyroidism. And I've depicted in the rectangle those with normal PTH levels, about 12 or 14%. Now, another thing that can affect PTH levels in primary hyperparathyroidism, just as in patients who are normal, is vitamin D status. And this figure is in international units, so I've drawn in here the 20 and 30 nanogram per ml 25-hydroxy-D level, and here's PTH, and the blue lines will enclose normal PTH levels with this assay. You know two things. One is, as patients become vitamin D deficient, PTH levels start to go up, even in primary hyperparathyroidism. And vitamin D deficiency is incredibly common in patients with primary hyperparathyroidism, whether you're going to use a cut point of 20 or 30. What has been shown is that patients with primary hyperparathyroidism, well, they have a high PTH, but if you add on top of that vitamin D deficiency, they get some further increase from secondary hyperparathyroidism that can be reduced when you replete them with vitamin D. So if you have a chronic excess of PTH, clearly the calcium is high. I've already emphasized why 125-dihydroxy vitamin D levels are high normal or slightly high. Phosphorus is variable. Remembering that 125-dihydroxy vitamin D increases the intestinal absorption of calcium, of phosphorus, but it also, the high levels of PTH promote increased phosphate clearance by the kidney. The net effect is usually a serum phosphorus that is often normal, may be low. And as emphasized on the previous slide, an increased prevalence of vitamin D deficiency, probably due to increased activity of the 24-hydroxylase, which converts 25-hydroxy-D to inactive 24-25-dihydroxy vitamin D. So you've established the diagnosis. What other ancillary tests do you need? Well, you need the calcium and the albumin. Obviously, you've gotten a PTH level. We want to see what the phosphorus is. Alkaline phosphatase is a marker of bone turnover and renal function. We want to measure the 25-hydroxy vitamin D to see if the patient needs replacement. Now, I've already mentioned the 125 is actually often abnormal, but we don't measure it. It doesn't add anything to our management of these patients. So it's not recommended to measure a 125-dihydroxy vitamin D. Now, certainly if you had a patient who presented with PTH-independent hypercalcemia and you're searching for the cause, here's where a measurement of a 125 can be very helpful. And we want to measure the urine calcium and creatinine to try and differentiate primary hyperparathyroidism from FHH, and also to assess for the risk of renal complications. So differentiating patients with primary hyperpara from FHH, we measure the calcium and creatinine in the blood and the urine. We calculate the fractional excretion of calcium. It's the same formula as the fractional excretion of sodium, except you're substituting calcium. And patients with primary hyperparathyroidism classically have an excretion greater than 2%. FHH less than 1%, there's this indeterminate range. Now, sometimes things aren't as clear-cut. There are limitations. About a fifth of the patients with FHH may not have a low fractional excretion of calcium. Vitamin D deficiency can lower the fractional excretion of calcium, even in patients with primary hyperparathyroidism. And there's a lower excretion of calcium by African Americans, whether they do or don't have hyperparathyroidism. So sometimes, even though we get this fractional excretion, we may have to scratch our heads a little bit. Now, when in doubt, there now are available some genetic tests looking for inactivating mutations of the calcium sensing receptor to define who has FHH. They don't pick up all the mutations. Maybe they pick up about 70 to 80%. But it is a test that can be applied when in doubt. Now, here's a favorite board question, both for internal medicine and I would guess for step 3. They're going to give you a young individual diagnosed with hypercalcemia on routine exam who has no complications of hypercalcemia. Their bones are normal, they're not having kidney stones, they will typically have a slightly high PTH, and they're going to give you in this question several relatives who have been diagnosed with hyperparathyroidism, underwent neck exploration, and remained hypercalcemic after the surgery. What test would you want to get for this patient? A parathyroid scan, a measurement of urine calcium and creatinine, screen for MEN1 genetically, or check an ionized calcium? And the answer is always measure the urine calcium. Failed surgery, asymptomatic person, FHH. And while I was thinking about boards, I put this figure in. We rarely see this manifestation of primary hyperparathyroidism anymore because we've diagnosed patients at such an earlier stage. But here's classic subperiosteal resorption of the bone along the lateral aspect of the middle phalanx. Now, an entity that is gaining increased traction in the literature is normocalcemic hyperparathyroidism, defined by a normal total anionized calcium. Now, about 10% of patients who have a normal total calcium, when you measure the ionized calcium, it is high. They don't meet the criteria for normocalcemic hyperparathyroidism. But if they're both normal and the PTH is high, and you exclude other secondary causes for an increase in PTH, such as vitamin D deficiency, or chronic kidney disease, or drugs like thiazides, or lithium, or drugs that inhibit bone resorption like denosumab or bisphosphonates, which can raise PTH levels, then you meet the criteria for normocalcemic hyperparathyroidism. Now, if they are vitamin D deficient and you replete their vitamin D, well, you may find on repeat testing that their calcium is high. They really have more classic primary hyperparathyroidism. If you have this entity, no reason to rush in and do anything. Follow the calcium, repeat it. We don't have a lot of good, large studies, evidence-based data, what happens to these individuals. It's an area of active investigation. But in some of the smaller series, about a fifth over a 3-year period of observation became hypercalcemic, and 40% developed symptoms, signs consistent with more classic hyperparathyroidism. I think we all recognize nowadays that in what we might consider the modern era of medicine, we now diagnose hyperparathyroidism at relatively early stages before there's bone destruction like we saw on that X-ray. The patients are typically with mild hypercalcemia, usually asymptomatic, without recurrent kidney stones or fractures. And if we monitor these patients, not all, but most tend to have a very stable course without the development of complications or worsening hypercalcemia. So, how do we treat hyperparathyroidism? The definitive treatment remains surgery if there are complications or the patient is symptomatic. If they're mild hypercalcemia and asymptomatic, we may elect to observe them, particularly if there's an increased surgical risk from comorbid problems. And there are some potential medical treatments. Bisphosphonates if the only problem the patient is facing from this is reduced bone density, or calcium mimetics, cinacalcet, a drug that binds to and activates the calcium-sensing receptor, lowering PTH and calcium levels. And I'll talk more about these as we go along. So these are the current guidelines in the 2014 iteration, recommending surgery for symptomatic patients, recurrent stones, more severe hypercalcemia. But if you're asymptomatic, the recommendations for surgery are that the calcium is more than 1 above the upper limit of normal. Patient has osteoporosis. Age less than 50, the concept being better surgical risk, longer time in adulthood to develop complications. GFR less than 60, or a urine calcium over 400 milligrams per day or evidence of renal calcifications. And this last one was not in the 2008 recommendations. Considering renal disease, if you look at patients with primary hyperparathyroidism, clinically about 10% will have recurrent stones, but if you image, about 15 to 20% will be found to have stones. If you look at it from a different perspective, if you go to a urology office and just say, let me look at the data on all your patients presenting with recurrent kidney stones, about 3% will be found to have hyperparathyroidism. It's now recommended renal imaging should be done to look for subclinical stone disease or calcifications within the kidney. It can be done with CT, but it's costly and there's radiation, plain X-rays or ultrasound. And if renal calcifications are identified, this is now considered a criteria to recommend surgery. You also, in some patients, want to assess risk of stone formation. And you should be aware there's a 24-hour urine that can be collected for stone risk. It looks at the excretion of calcium, uric acid, cysteine, citrate, number of other things, and gives some risk for renal stones. What about fracture risk? Well, DEXA still remains the gold standard for assessing fracture risk. But it's important to understand that hyperparathyroidism preferentially causes loss of cortical bone rather than trabecular bone. When you get a DEXA, remember that the spine is almost all trabecular bone. The hip is about 50% cortical, 50% trabecular. So if you want to assess cortical bone, and you do in primary hyperparathyroidism, you need a DEXA at the distal 1/3 radius, which is virtually all cortical bone. At UH in EPIC, when you order a DEXA, you're getting hip and spine. And if you want the distal 1/3 radius, which we do in our patients with hyperpara, you've got to order it as a separate order as a peripheral DEXA. At the VA, when you order a DEXA, they do all 3 sites. You don't have to order it separately. Now, anybody who treats patients for osteoporosis should be familiar with FRAX. FRAX is a tool, it's available on the internet, that uses a very complex formula developed from a huge database, and you input the patient's bone density, age, height, risk factors for osteoporosis such as exposure to steroids, smoking, other things. You enter this, push the button, and it gives you the 10-year fracture risk. FRAX, however, has not yet been applied to patients with primary hyperparathyroidism, so it remains a bit unclear whether it's as predictive of fracture risk in the population of patients I'm talking about today as it does in patients with osteoporosis. Now, another thing to consider is how well does DEXA predict fracture risk in hyperpara? You know, if you go to bone meetings they will talk not only about bone density and fracture risk, but a lot of talk about bone quality, which is a much harder parameter to understand and to quantify. You can get some information by doing quantitative CT scans of vertebral bodies, but again, radiation and cost. There's a new tool that is being used more commonly. We don't have it here, we don't have it at the VA, but it's called a trabecular bone score. It's a software patch to current DEXA instruments that gives you some textural analysis of the DEXA images and gives information more about bone quality. And with the application of this trabecular bone score, you may find you have two patients with the same bone mineral density, but one's at higher risk of fracture. The recommendations from the consensus is that we should assess risk of spinal fractures with either X-rays, trabecular bone score, or spinal CT. Now this slide is got a lot of important information on it. These are data collected and analyzed from the group at Columbia, where they have a large number of patients they've been following for over 15 years now, probably over 20 years, with hyperparathyroidism. This group was observed for up to 15 years, and note two things. Over this 15-year span of time, a significant reduction in cortical bone, measured at the radius, not much change at the spine. Contrast this with the group that had successful surgery, and within a year, significant increases in bone mineral density that are maintained for up to 15 years, and I'm sure beyond. Now, if we're not going to have patients undergo surgery, can we treat them with more classic drugs for osteoporosis? And almost all the bisphosphonate data in hyperparathyroidism has been done with alendronate. So again, I believe this study was also out of Columbia. They took they took patients they were observing for primary hyperparathyroidism. Those in the darkened bars, 1 and then 2 years of treatment with alendronate, showing increase in bone mineral density in all sites. The open bars are the group that got placebo for 1 year, and the second year they got alendronate and had some improvement during that second year. So alendronate is a potential therapy. Another thing to consider, what about bone turnover markers? Meaning tests that assess osteoblastic and osteoclastic function. Bone formation osteoblastic markers like bone-specific alkaline phosphatase, P1NP, or osteocalcin. Bone resorption markers, these can be measured usually in the urine. There are now some blood tests to measure C and N telopeptides or pyridinoline crosslinks, markers of bone resorption. If you look at patients with primary hyperparathyroidism, about a half will have increases in these bone markers. If we don't do anything, they don't usually change, they stay stable, but we can decrease them with surgery, estrogens and bisphosphonates, although not with cinacalcet, that drug that activates the calcium sensing receptor. And at this point, the role in using these bone markers in monitoring, following, decision-making in patients with primary hyperparathyroidism is not very well established, and I think most people don't routinely measure them, except probably for the alkaline phosphatase. So if we take patients with primary hyperparathyroidism, treat them with bisphosphonates, we can increase bone mineral density at the spine and the hip. We can decrease the bone turnover markers. Calcium levels don't change, but there's no fracture data yet, whether they reduce fractures. And the consensus is that if you have a patient with low bone mineral density who is not a candidate for surgery, alendronate is a medical option. Other things to consider. In the era when patients presented with hyperparathyroidism with fairly advanced disease and more marked hypercalcemia, it was identified that these patients have increased cardiovascular morbidity and mortality. But what about the patients we typically see now with mild asymptomatic hyperparathyroidism? No prospective studies. There are studies that do show some variable effects on cardiac risk factors, some showing increased vascular calcifications or changes in echocardiographic function. But most studies don't show any benefit of these cardiac events with successful surgery. So the consensus is that evaluation of hyperparathyroidism should not include assessment of cardiovascular abnormalities other than to assess their risk for surgery. And we shouldn't use these cardiac manifestations in making decisions whether or not to recommend surgery. Neuropsychiatric disease, again in the older era of hyperparathyroidism, lots of neuropsychiatric type symptoms, and even now clearly a higher risk in mild hyperparathyroidism of weakness and fatigue and depression, poor concentration, but not much data on what happens with surgical versus observation. Some studies show some improvement in depression. Some, but not all, studies show some improvement in a few parameters of quality of life, but the results are not consistent. And the consensus of the experts is at this time, there still is insufficient data to predict in a single patient if neuropsychiatric symptoms will improve with successful surgery, and so those are not typically included in the algorithms in making decisions, surgery versus no surgery. What about medical therapy? Well, either before surgery if their surgery is planned, or long-term if the patient is going to be observed. Should we restrict calcium? Yes, this might lower the calcium in the blood and in the urine, but it may make the bone disease worse because the patients are in negative calcium balance, and it may worsen the osteoporosis. So pretty much everybody agrees there's no rationale to restrict or add calcium to these patients. Keep them on a normal calcium diet. Vitamin D. I've already mentioned the majority of patients with primary hyperpara have low 25-hydroxy-Ds. And that's likely because of the increased activity of the 24-hydroxylase, which inactivates it, or possibly increased conversion of the 25 to 125-dihydroxy vitamin D. They have high normal levels of 125. There is some modest inverse relationship between vitamin D deficiency and increased weight of parathyroid adenomas. And we do know that if you replete vitamin D, the patients are less likely to develop postoperative hypocalcemia. So we want to get the vitamin D back up before surgery to reduce the risk of postoperative hypocalcemia. And if we're going to observe the patient, we want it back up some to improve bone health. How do we get it back up? Well, here's a study a number of years ago now. Michael Hollick was one of the authors of this. They took patients with primary hyperparathyroidism who were vitamin D deficient, gave them high-dose vitamin D, 50,000 units a week for a month and then 50,000 units monthly. On average, calcium levels did not change. PTH levels went down about 20-25%. As did bone markers. No change in the average urine calcium excretion. However, 3 of their 25 patients did develop marked hypercalciuria, more than 400 milligrams per 24 hours. If you look at other studies, some studies have shown no increase in blood or urine calcium when you correct vitamin D deficiency in these patients. Others have shown a subset will develop either a rise in serum calcium or hypercalciuria. But unfortunately, most of these studies are relatively small and uncontrolled to really provide definitive information. And the consensus is, yes, we should replete vitamin D in these patients, but avoid the bolus large dose vitamin D. Give them 600, 1,000 units a day. Monitor the calcium in the blood and in the urine, and the goal will be to get the 25-hydroxy-D in the 20 to 30 nanogram per ml range. Now, cinacalcet, I've mentioned this several times, is a drug developed to bind and activate the calcium-sensing receptor. It's used most commonly by Dr. Abrio to treat secondary hyperparathyroidism in patients with CKD. It also was initially approved to lower the calcium in patients with parathyroid cancer. And it's now approved to treat patients who need treatment for hyperparathyroidism but are very poor surgical candidates. So here's some data looking at patients who were started on and titrated up on cinacalcet, showing normalization of the serum calcium, decreases but not normalization in PTH levels, but no improvement in bone mineral density. So we see very modest changes in PTH, but 80 or 90% of the patients with proper titration can achieve a normal calcium level. No improvement in bone mineral density, some GI and musculoskeletal side effects, and the drug is fairly costly, $7,000 to $8,000 a year. And when you do a cost-benefit analysis, it's actually more cost-effective to have a patient undergo surgery than be treated with this drug for a couple of years. So the FDA has approved cinacalcet to treat patients with severe hypercalcemia who, for other reasons, are unable to undergo parathyroidectomy. The consensus is that for sporadic hyperparathyroidism, we use the same FDA indications. If the patient's a surgical candidate, but they're a poor operative risk, this is a medical option. Now, a little more difficult to tackle are patients with familial hyperparathyroidism, let's say MEN1, where there's typically 4-gland disease, hyperplasia. The traditional surgery for this is to do a 3.5-gland parathyroidectomy to try and avoid postoperative hypocalcemia. But if you leave a remnant, the patient maintains their genetic mutation, the remnant hypertrophies, and these patients are at very high risk of recurrent hypercalcemia. And when that happens, surgery is an option, but also cinacalcet can be considered. What about imaging? Imaging is used for preoperative localization, not for diagnosis. Okay? Our biochemical test to define who has hyperparathyroidism, the sensitivity of the biochemical test far exceeds the sensitivity of the imaging studies. So there is no need to image in a patient where you've made the decision that you're going to observe them for at least a period of time to see if they develop complications. The tests that we have, ultrasound is very highly operator dependent. I will tell you, 2 years ago, we rarely saw a parathyroid adenoma at, I guess it was UH at that time. But since the arrival of Dr. Chatta in the radiology department, who has trained the technicians, we now probably pick up 60, 70% of adenomas less likely to pick up hyperplasia or multi-gland disease if the patient has normal renal function. Same thing with parathyroid scans. Sensitivity is highly variable, probably in the 80-85% range for picking up an adenoma, much less sensitive in people with normal renal function of picking up multi-gland disease. So there are going to be patients who have hyperparathyroidism with negative imaging studies. Operative approaches traditionally was bilateral cervical exploration before there was decent imaging. And in experienced hands, without prior imaging before surgery, and skilled parathyroid surgeon would cure 90-95% of these patients. The benefit is it reduces the risk of missing multi-gland disease. It is preferred if the patient is suspected to have multi-gland disease or you are not sure where it is with your non-invasive imaging studies. Nowadays, I think most surgeons would prefer minimally invasive surgery, that is, image-guided surgery, suited for those where we see the adenoma on a preoperative imaging study. And it's best done when you couple it with intraoperative PTH monitoring, keeping in mind the half-life of PTH is 1 or 2 minutes. So you measure a PTH before you remove what you suspect is the adenoma. You wait 10 minutes and you repeat a PTH, rapid turnaround, you get the results while the patient is still in the OR. And if you've had successful surgery, it will decrease by more than 50%, usually by 70 or 80 or 90%, or it falls into the normal range. Now, it's important to understand that if the PTH does not fall, then the surgeon will need to extend the incision looking for why it didn't fall. There's probably more parathyroid tissue responsible for the problem, meaning even those doing minimally invasive surgery have to be skilled in doing bilateral explorations. And clearly, the most important diagnostic tool for hyperparathyroidism is a skilled surgeon who knows their way and understands parathyroid disease. So this is the slide that I showed you before. I've put in capital letters guidelines. These are not laws. They're guidelines. And you need to understand that, look at each patient individually, discuss it with the patient. Now, I will tell you, they might be laws if you're taking a standardized test, but when you're faced with a patient, they're guidelines. High calcium, very high calcium, recurrent stones, surgery. Asymptomatic, surgery if the calcium's greater than 1 above the upper limit of normal, osteoporosis, age less than 50, low GFR, urine calcium over 400 or evidence of renal calcifications. Now, do I violate this rule? Yes, I'll give you a couple of examples. Saw a patient about 3 months ago, I think she was 71, really good health, has primary hyperparathyroidism, had none of these indications. We had a conversation, and she preferred to have a surgical cure instead of repeat examinations every 6 months and multiple testing. She had her surgery, her calciums are normal, she's doing fine. Other situation, a patient who meets none of the criteria except their GFR is less than 60 and they're 82 years old and they've had hypertension for 20 years. You know, is the GFR low because of hyperpara, or is it low because they're 82 and had hypertension? You know, and they're a poor operative risk. I follow these patients. They might require surgery, but again, just want to emphasize guidelines, not laws. So if we don't recommend surgery, if we're going to monitor these patients, it doesn't mean we're going to ignore them. We're typically going to check their calcium. The guidelines say annually, depending on the degree, every 6 or 12 months. We need to reassess their skeletal health with DEXA and an assessment for vertebral fracture every year or two. Monitor their GFR, look for renal calcifications, monitor their urine calcium excretion. And if during the course of monitoring, if their calcium starts to rise, if they start to get osteoporosis, or they get a significant reduction in their bone mineral density, even if it doesn't meet the strict criteria for osteoporosis, or they have evidence of a vertebral fracture, declining renal function, or evidence of kidney stones on imaging, then these patients should be considered for surgery. Normocalcemic hyperpara, again, this is an area that's still being investigated, but the current consensus is monitor the calcium and the PTH and the bone density. If they progress to hypercalcemic hyperparathyroidism, apply the same criteria that we use for the patient who would have presented with a high calcium initially. Or if they start to get progressive bone problems or renal problems or stones, then they should be considered for surgery. So I come back to the patient that I presented at the top of the hour, a 62-year-old man who's got recurrent stones, who's got a fragility fracture and a calcium of 12.1, even corrected a bit higher. And I hope I've convinced you that this patient doesn't need any of these. He needs a surgeon who knows what they're doing. Now, you might say, well, what about alendronate? We can maybe take care of the osteoporosis. That's true, but it's not going to lower his calcium that's 12.1. What about giving him cinacalcet? Well, we might lower the calcium, but it's not going to do anything for his bones. Okay? So this is a surgical candidate. So I thank you for your attention, and yes, John.
Normocalcemic hyperparathyroidism. What would be the trigger again?
Well, I guess there might be a number. Sometimes people are getting PTH levels for patients with vitamin D deficiency, and you may find the calcium's normal. Now, you can't interpret that till you replete the vitamin D. Sometimes the patient might be having complications. Let's say the patient comes in with recurrent kidney stones. Might be something you want to consider. Or they've got, they're 43 with an unusual degree of osteoporosis. You're really searching for unusual circumstances that are leading to a particular problem. But we're probably missing a lot. Right. Other questions? Comments? Yes, Larry.
You mentioned that there's no evidence of increased cardiovascular disease with mild hyperpara. What's the latest thinking about calcium ingestion and coronary calcification?
Honest truth, I don't know. You read the same reports in the newspaper that I do. I guess there was that one report very recently which seemed to support what Dr. Muslow's been preaching for years, that we shouldn't be giving people calcium, right? That there was an increased cardiovascular risk. Listen, you're not the first person that asked me that question. The first person that asked me that question was my wife. And I said, I don't know. She's still taking her calcium right now. Sorry, Dr. Muslow. Other questions? Okay, thank you.